Hey everyone, it's Angry Bill for Prehospital Wisdom. If you like the content you're seeing here, make sure to like, comment, subscribe, share. It helps the algorithm, helps get the word out. And if you like it, maybe other people will too. Continuing in our discussion of simplifying our jobs, begun in part 1 and part 2, we move on to taking the easy road. This is all based on the point that you have 3 finite resources when dealing with a patient: brain cells, air in your lungs, and 2 hands. These are the things that we need to free up so they can be doing the most productive thing that they can. This trick is to take the easy road. This is permission to be lazy, as long as it gets your patient to the desired outcome just as well as the harder road. The easier road involves making the lazier choice if it doesn't the job you need it to. I'm not advocating for a paramedic care to patients at an EMT level, or for an EMT to provide first responder level care. It's absolutely necessary to not slack on your ability to provide care. What I am advocating is choosing the easiest, simplest path to your goal. The first step here is to think about what your deeper goal is. For example, your goal isn't really to start an IV. Your goal should be to establish a way to deliver IV medications and/or fluids. What's the easiest way within the constraints of your protocols to deliver fluids and medications? Your goal isn't to intubate a patient, it's to secure their airway. Your goal is not to deliver IV fentanyl, rather your goal is to start to relieve a patient's pain. Think about your actual goal and choose the easiest way to completely meet that goal. For example, I'm a fan of simpler adjuncts like an iGel, especially in the initial stages of cardiac arrest care. The goal of intubation is to control an airway and enable simpler ventilation, right? Doesn't a supraclavic airway do that? An endotracheal tube involves a more complex process to place and requires a higher level of constant monitoring. I can drop an iGel and mark airway off my list, leaving me able to move on to another task and have synapses free sooner for other mental tasks. By the way, I often come back to the intubation later after things settle down, which isn't consistent with part 2's point of only doing something once, but whatever. Consider the setting of a medical cardiac arrest. In that setting, you will eventually have the goal of establishing IV access for medication administration. Your goal is not to start an IV line, though. It's to be able to deliver IV medications and fluids. If you can start an IV quickly on the first try, then do it. If the IV will not be easy, however, it simplifies our job when treating a cardiac arrest to move straight to an IO placement instead of screwing around missing improbable IV lines. I understand that there are benefits of IV lines over IO lines, for example, but if there's no obvious veins staring at me, I will be more likely to just establish cross-venous access off my to-do list. Thinking on the subject of IV access, another trick that I like is to start 2 IV lines in the same arm, saving me the need to physically move to the other side of the ambulance, place a second tourniquet, and start the second line on the opposite arm. My goal is to give myself and the hospital the ability to deliver fluid quickly, not to start an IV in each arm, right? I can auscultate a blood pressure and grab a pulse off that at the same time. Why count a pulse and then take a blood pressure as 2 separate steps? Do them both at the same time. Shoot, even better than all that is an NIBP automatic blood pressure cuff that collects a blood pressure for me, marks blood pressure off my to-do list, and leaves me available to handle something else, as long as it's giving reasonable numbers that is close to what I auscultated. Rolling a patient to their side before immobilizing them opens the back of their clothing to be cut from waist to collar. You can then check their back before they're immobilized. When they're rolled back supine, the shirt and jacket lift right off. I hate arriving on scene to find someone immobilized and still wearing a shirt. How good was a posterior chest exam really? There are tons of ways to make your job easier like this if you know how to find them. Working in the opposite direction, we can occasionally make our jobs tougher by performing tasks that don't really need to be done. A perfect example is illustrated by a seizure patient. The patient has had a seizure and thus might have need for anti-epileptic medications later, right? So you can start an IV. Wait, can't midazolam be delivered intramuscularly or intranasal? Same thing for IM antiemetics. Why start an IV? Simplify your job if you're in the weeds. One of the best ways to not perform unnecessary tasks is to not completely interpret an EKG. I know that this sounds weird coming from an EKG instructor, but think of a wide complex tachycardia. The sicker the patient, the more important it is to simplify your job. Thus, in the sickest wide complex TAC patients, like pulseless ones, it doesn't matter if the rhythm is VTAC or SVT with aberrancy. Electricity works for either rhythm. Blast the patient and save the detailed EKG interpretation for when you aren't in a hurry, like, say, after the call. There's no need to waste your time looking at concordance and QRS morphology and all the other findings when your patient is sick and needs your attention. I have a separate post about not interpreting wide complex tach. The take-home point that I want to make about the easy road is to not perform tasks that don't need to be done. Does the patient in the stabbing scenario way back in part 1 need to be immobilized? Check out part 1 if you haven't seen it. And no is the answer. Does he need to have his sugar checked? EKG monitoring? If you're convinced that a task needs to be done, then do it. I'm not trying to talk you out of caring for your patient in a complete and competent way. Treat your patient to your training level. But when a patient doesn't require mobilization, don't immobilize them. If hypoglycemia isn't a likely problem, then don't waste your time checking the patient's blood sugar. Adding steps and tasks is certainly something to be avoided. What else could you be doing with the time that you can save by being lazy? Here's a take-home message. The minimum that you should be doing with your newfound free time is to be thinking. A paramedic's or an EMT's most important piece of equipment lies between his or her ears. Making your list of differential diagnoses more complete, thinking about your patient's presentation, thinking of anything that you may have missed, and other cognitive tasks are actually important. I would much rather be thinking, re-examining, re-evaluating, and questioning than starting an unnecessary IV line any day. These more thoughtful processes can improve patient care and outcomes while lowering our error rates as well. Let me know if you agree or disagree. I am sure there's people on both sides. If this channel is helpful, make sure to like it, subscribe, share, let people know about it. One way or the other, this is Angry Bill for Pre-Hospital Wisdom. Stay safe.